Good morning, everybody. My name is Katie Dain. I'm the CEO of the NCD Alliance, and it's a pleasure to be moderating this session entitled From Commitment to Action, Advancing Sustainable Solutions for Non-Communicable Diseases, Implementing Integrated Responses and Ensuring Equitable Access to Treatment, co-hosted by the NCD Alliance and Sanofi. The aim of this session is to really provide a timely reflection on the recent UN high-level meeting on NCDs and mental health that took place in New York. Just 3 weeks out from that meeting, we want to deep dive into the key issues that were discussed, what was agreed in the political declaration, as well as what was and what wasn't missed, and most importantly, what comes next. We're going to particularly be focusing in the next 90 minutes on the health systems and the access components of the declaration and the NCD response. But we'll also be covering a whole range of other issues, from governance to financing to the role of civil society. And throughout the conversation with our panelists, we really want to focus down on the solutions, on what's working in countries, in regions, and how we can replicate those solutions to ensure progress is made over the next 5 to 10 years for NCDs. We have an absolutely fantastic lineup of speakers for this session. But before I start introducing our first speaker, let me provide a few kind of framing remarks about the high-level meeting from an NCD Alliance perspective. As you might know, the road to the high-level meeting has been a fairly long one. It's taken 2 years in the lead up to this fourth high-level meeting on NCDs. And we at the NCD Alliance have been involved in all 3 of the past high-level meetings for a very specific reason, for the fact that these high-level meetings really take an issue from being a technical issue being discussed in Geneva to a whole-of-government development issue being discussed in New York at heads of government and heads of state level. And we really see it in the round. We see the declaration that was being discussed as important, the words, the specific language that's used, critical. But it is much bigger than that. It's the whole ripple effect and the momentum that these high-level meetings create for an issue such as NCDs. It was obviously 7 years since the last high-level meeting in 2017. And at this one, hundreds of governments showed up at ministerial or heads of government level, made statements on NCDs about their national response, as well as the importance of NCDs being a development priority, and negotiated a new declaration with new commitments and a roadmap for action. I think it's fair to say that the backdrop of this high-level meeting has been a challenge, to say the least, both from a perspective of the global NCD response, the fact that we are significantly off track to date. Only 19 countries out of 194 are on track at the moment to achieve Sustainable Development Target 3.4 to reduce NCD mortality. And of course, the geopolitical backdrop of the high-level meeting has been extremely challenging. And the negotiations, we saw through this. In a way, the negotiations of the declaration were a mirror to the fragmented world that we are living in today. But in terms of the content, whilst it certainly wasn't perfect, there are some really important aspects of the declaration I wanted to highlight before we get into the discussion. Number one, mental health has been included in the declaration for the first time in a meaningful way, both as a public health issue in its own right, as an issue that is really intertwined with so many of the other diseases, whether it's cancer, diabetes, cardiovascular disease, chronic respiratory. For the first time, this declaration included a set of targets. We haven't actually seen that in a high-level meeting on NCDs before. Both fast-track targets for 2030 and tracer targets across prevention, financing, data and surveillance, and primary healthcare. Important. There was a really strong focus on primary healthcare and integrated services, as well as improving access to essential medicines and technologies, which we'll very much dig into today. As well as, I would say, the weaker areas where we fell short in the declaration are aspects around prevention, the health-promoting environment. We saw a significant watering down of the prevention section in the declaration during the 3-month negotiations in New York. And that's not new. We've seen that every time in these high-level meetings and with the NCD agenda. The other aspect that perhaps fell short, but perhaps not surprising given the current landscape, is the financing side of it. Again, we'll dig into this into the conversation today, but financing has always been a real Achilles heel of the NCD response. And the commitments made are just not up to what's actually required to really create that urgency and that sustainable response that we need to see in low middle income countries particularly. And then finally, civil society, only mentioned once in the whole declaration, was a big disappointment from a civil society perspective, of course. At the NCD Alliance, we don't look at these high-level meetings as things that are going to change the NCD response overnight, of course. It's, in a way, a signal of political intent for the issues. It's an opportunity to really reposition NCDs at the political level. It's also an entry point for advocates at the national and regional level to take to their governments following the high-level meeting. And given the targets, it's a really useful accountability framework. But it's also what happens next that's obviously the most critical. How do we use what was agreed? How do we use the momentum that it's created to really ensure that at the national and the regional level, where the rubber hits the road, that we're actually going to make a difference and we're going to see progress that's so necessary. So with those framing introductions, it's my pleasure to introduce our first speaker, our keynote speaker for this session, Dr. Mohamed Yaqub Janabi, WHO's new Regional Director for Africa. He was appointed in May of this year, is a cardiologist by training, so very much part of the NCD family. And he'll be presenting the burden of NCDs in the Africa region, the challenges being faced by the region, as well as how the region is really responding to NCDs. So let me introduce and pass over to you, Dr. Janabi.
Thank you, Katie. You didn't finish, I'm still under probation. It's just 90 days since I was. So good morning to everyone. It is a pleasure and honor to join you today at this important panel discussion, co-hosted by Sanofi, WHO, NCDs, and the mental health team. As you say, this is particularly a meaningful moment for me. My first World Health Summit as the Regional Director of WHO. I started my job on the 1st of July of this year. And as a clinical specialist, I must share that I am a cardiologist by training. So NCD is not only a professional priority for me, they are quite literally close to my heart. And if I have to be personal, they killed my father. He had a terrible heart attack. So we gather here to confront a challenge that is both urgent and deeply personal for millions across our continent. The growing burden of non-communicable diseases and the mental health conditions. And I have to put one point very clear. For our continent, Africa, it's really a bad coincidence because while we are still fighting non-infectious diseases, TB, HIV, tuberculosis, malaria, we imported NCDs. And I said imported, I'll tell you why. Let me begin with a simple truth. We are really at the critical juncture. The burden of NCDs in our continent is rising rapidly, and it's driven by multiple reasons. I was a CEO of a heart institute in Tanzania for 8 years, and coincidentally, my successor is just sitting in front of me. So we have a problem of urbanization, we have a problem of lifestyle changes, weak health systems, and limited access to early diagnosis and treatment. I was citing an example yesterday. I was in a panel. When I was going to school, I used to run 1.5 kilometers to go to school. I meet friends on the road. Today, my kids, if they are not picked by school bus, the driver will take them to school. When I was little, we used to run around, play football or soccer. Today, I have to take a rifle to remove my son from PS5. He doesn't need many friends. And he plays, one of his friends is in Belgium now. They talk as if they are just sitting next to each other. So our lifestyle, it has changed all of a sudden. So cardiovascular diseases, diabetes, cancers, chronic respiratory diseases, and mental health conditions are no longer diseases of the affluence. They are disease of inequality. Just a few weeks ago, I was at the General Assembly in New York. We had a strong political commitment to address NCDs. The declarations were bold. The language was very inspiring. But let's be frank. Declarations are not yet matched by the resources needed to deliver. Financing is not keeping pace with the crisis. And in Africa, the gap is just stark. If you look to our 2025 WHO NCD Progress Monitor, NCD now account for 37% of all the deaths in the African region, with 64% of those deaths occurring in people under 70 years of age. What do we call that? Premature mortality. So premature mortality from NCDs, they range from 36 to 70% in some countries. And yet, many African countries spend well below 12% of their health budgets on NCDs, while primary health care remains chronically, and I say chronically, underfunded. I have 47 member states, so I have a glimpse of their budgets in primary health care. Less than a quarter have met the Abuja Declaration, which was 20 years ago, of allocating 15% of the national budget to health. I always remind ministers when I meet them, respectively but very firm, that the responsibility of health lies within the government. Development partners can support, but domestic commitment is the foundation. And let me be even more direct. Investing in health is not a cost. It is an economic strategy. In fact, the ministers of finance should be approaching the Minister of Health to offer more funding, because a healthy population is more productive, drives revenue, and ultimately strengthens the economy. Health is an engine of development. But what happens to many of the 47 member states is a Minister of Health who is running around to meet the Minister of Finance. The data is compelling. In our low and middle income countries, NCDs account for 26% of the total health spending, second only to infectious diseases. Yet, despite the burden, NCDs receives what? 1 to 2% of all official development assistance for health. WHO, now we estimate that investing just 84 cents per person per year is cost-effective intervention, known as, in our documents, as best buys, could save millions of lives and generate economic returns of up to $7 for every $1 which is invested. This is not just about saving lives, it's about saving the economies. Let me share with you a story while I was still actively practicing back home. It moved me deeply, and my colleagues here from Tanzania can tell you. We admit a patient, a teenager, was diagnosed with a heart condition. was coming from the rural area, the nearest clinic miles away or kilometers away. His father sold his belongings, a bicycle and livestock, just to pay for the transport and the medicine. And usually when we ask them, why didn't you wait until the next harvest? And the answer is usually, if I wait, I may lose her. She's my harvest. And those are the realities. People sold their belongings, yet the patient is still dying. So you are recycling poverty. Because out of pocket, I move. Since I started this job, I've already moved to 13 of my member states' countries. So what does it take to move from commitment to action? First, I think we must strengthen primary health care as the foundation of integrating NCDs and mental health services. This means ensuring that every health facility, no matter how remote, and let me give you perspective. When we say remote in Africa, it's really remote. We have Ebola now in Kansai province in DRC. From Kinshasa to Mulabe, where is the epicenter, is a 4 days drive. And you are dealing with hemorrhagic fever there. I have a team there, and I have to say today, it's a 15th day. We don't have a new case, so we are crossing our fingers. The team is working very effectively, and I'll be there the end of next week. The second, we need sustainable financing mechanism. WHO Afro is working with countries to develop investment cases that demonstrate that economic returns of NCD prevention and early treatment. We are also advocating in innovative financing, include health taxes, or we call them sin taxes, on tobacco, on alcohol, and the sugary products. And I have to say, what we call best bias intervention. We are still having trouble because taxation with political influence, I think we are going to discuss it in depth. And my friends, my colleagues, when you say I have a sweet tooth, no, you don't have a sweet tooth. You are addicted to sugar. So these are not only cost-effective, but politically smart, and they save lives, and they generate revenue. Third, I think we must integrate mental health into universal health coverage and primary health care. Mental health is too often neglected, yet it's inseparable from physical health. We are supporting countries to scale up community-based mental health services and reduce stigma. Let me also highlight that progress is possible and happening. Through the PEN Plus strategy, 20 African countries have expanded access to care for severe NCDs like type 1 diabetes, sickle cell diseases, rheumatic heart diseases. I'll give you an example. In Malawi, over 440 clinicians and nurses have been trained, and 6 secondary level facilities are now providing PEN Plus care to hundreds of patients. In Liberia and Rwanda, decentralized services have significantly increased access to diagnosis and treatment for underserved populations. These are powerful, indeed powerful examples of what happens when commitment is matched with investment. Let me also emphasize equity must be at the heart of our responses. Rural communities, women, people living with disabilities, and the poor are disproportionately affected by NCDs and mental health conditions. Strengthening health systems must mean leaving no one behind. So a call for action, colleagues. The time for pilot projects and fragmented efforts is over, because pilots start with pilots and they end up with pilots. The time for bold, coordinated, and sustained action is now. We have the knowledge, we have the tools. What we need is courage. The courage to invest, legislate, to lead. Primary healthcare must be our foundation, equity must be our compass, and accountability must be our standard. Let us not wait for another summit, another declaration, another crisis. Let us act decisively, collectively, and urgently. And let me take this moment to recognize Sanofi, not just as a sponsor of this panel, but as a valued partner in the fight against NCDs. Your commitment to innovation, access, health system strengthening is helping us move from commitment to action. We need more partners. When we say domestic financing, when we encourage, when advocate, does not mean stop talking with our partners. It's a transition, it's a process. It will never be a 100 meters race. Let me close with a proverb from my continent. When the roots are deep, there's no reason to fear for the wind. If we invest on primary health care, I don't have to worry, because I can pick the diabetes, I can pick the hypertension right from the primary health care. So let us deepen our roots in our policy, in our partnership, and in our purpose, so that our health system can stand strong against any storm. And I can't wait for that day when our ministries, they are really going to be ministries of health, but not ministry of diseases. I thank you.
Do you want to take a seat? Yeah. Thank you so much, Dr. Janabi. If you take a seat, and I'll introduce our other panelists who are going to be joining us for the panel session. So very pleased to introduce Emanuela Salasi Homono, a diabetes and adolescent health advocate and Secretary General of the Diabetes Youth Care in Ghana, and also a voice of Pen Plus. Emanuela, please join us. Also joining us is John Fairest, the head of the Global Health Unit at Sanofi. John, welcome. And Gerald Lazar, Global Equity and Fund Senior Portfolio Manager at KfW Development Bank. Gerald, please join us. Thank you. So we're going to structure this conversation in two parts. The first is kind of a general kind of reflection from our panelists on the high-level meeting and the declaration. And I think Dr. Janabi set a very good kind of scene setter around some of the themes and some of the priorities that we heard and need to hear more of. And then in the next round, we're going to be really focusing on what comes next, particularly also really focusing in on some of the solutions, as I mentioned earlier. So Dr. Janabi, let me come back to you first, if that's okay. I mean, you've pulled out so many important themes in your keynote, from primary healthcare to financing to having equity at the center of the NCD response. I'd like to hear kind of a candid perspective from you, if I may, about the political declaration from an Africa regional perspective. Where did you see the things that were missed? Where did you see the issues that were kind of gained through the declaration? And how do you see this declaration really galvanizing leadership and action across the region?
No, thank you, Katie. Is it on?
It should be.
Can you hear me? Thank you, Katie, for the question. As I hinted on my speech, one, I'm glad that during the declaration, the discussion is still ongoing, but at least one of the gains was elevation of the mental health to the same level of urgency as other non-communicable diseases. That was really, to me. But again, there have been so many declarations. wishful now, this should be time of implementation. Because declaration is one thing and then implementation is the other thing, especially in our continent. But to me, the political declaration which was adopted in the high level 4 and grounded in human rights, it calls for whole of the government and whole of the society approaches to have a sustainable financing, to have a stronger health system, in which I hinted. For now, for our continent, we have to invest on primary health care, especially for what has happened beginning of this year. Because waiting for complications to happen, whether it's a kidney disease, whether it's a heart disease, with a heart at a tertiary level, is a very costly exercise. I can cite you an example. A patient with a kidney failure, their dialysis is $70. Now imagine you have 3 sessions in a week. That's 210. How many people in the continent can? So, despite the strong language, financing commitments remain vague, and the pace of implementation is still slow. The equity gap in access is still huge, I mentioned in my speech. So wishful, these equity inequalities can be taken now in action rather than declaration after declaration after declaration.
Thank you. And Gerald, let me bring you in. I mean, financing has come up a lot already in the conversations. It really is kind of, one of the biggest challenges that we face in the NCD space, one of the most underfunded global health issues, as Dr. Janabi highlighted in his keynote. And development financing particularly has been pretty elusive, less than 2% of development assistance for health. And obviously, given the current state of global health financing, that is obviously, a significant challenge. Against that backdrop, how do you see countries scaling up financing for NCDs and health systems strengthening particularly?
Thank you, Katie. Good morning to everybody. I'm happy that so many people are here. And thank you, John, Sanofi, and you for inviting me. Feel honored. Let me also start with a short personal story from my life, as you also did, Mohamed. So my father also suffered from diabetes when I was a little boy, and at least insulin wasn't an issue back then. I grew up in GDR, so in East Germany. I would consider the country maybe being a middle-income country by our today's definition, but at least the country had universal health coverage and had a government health insurance scheme, so that was not an issue. But a couple of years later, he also developed a colorectal cancer, which was first not diagnosed, and then after he complained about pain, they tried with the back then traditional methods of physical examination and X-rays to find out what's happening, and then they've sent him to Berlin, here to the Charité, which was back then in GDR the excellent center of health in East Germany, where they diagnosed him properly. But they also realized that treatment wouldn't work anymore, so he passed away. Why I'm saying that is that, yes, we had the universal health coverage there, that was okay, but in terms of proper diagnostic tools, for instance, for those cancer diagnosis, the modern and better technologies which were already available in the late 70s or 80s, like CT, MRI, or molecular testing, was not available due to financial but also technical constraints, which led to a situation where in East Germany, people living with cancer had only half the survival rate of West Germany. So also inequality back then within a German-speaking system. So inequalities in access to quality healthcare on a global scale, of course, are much bigger than my family example from back then between East and West Germany. But I think that's why we are here today, also at the World Health Summit, to take responsibility and discuss our experiences and solutions to close this global and local gap, to strive for health equity, right? Coming to your question, what countries can do or could do, also from our perspective as a development finance institution, and you, Mohammed and Abi, already, I think, touched upon most of them, and let me pick like 3 of them. So I would say domestic resource mobilization, you mentioned already, and innovative financing, I'll come to that in a minute, and private sector engagement. Well, of course, as you said, right, governments need to raise their local health budgets, that's foremost. We can discuss sin taxes on tobacco and alcohol, very good, but this also only would work, I guess, if the tax authority and the system is working properly, that you do not sell the cigarettes and alcohol, besides the shops, and you, at the end of the day, do not achieve or do not collect the relevant tax. And if you do not use the tax to exactly address the NCDs, but you use it to cover the overall budget deficit, then this is also not leading to our preferred outcomes or what we want to address. The second part is what I said, the insurance or the universal health coverage that I experienced, I took it as given, even in this little GDR. Universal health coverage or national health insurances is a tool of domestic resource mobilization. And yes, DFIs can and do support that. We can come to this in the second part when we discuss some examples. And the other is to improve, financial protection and sustainable funding. Then innovative financing, I think many of us know those topics already, and I don't know whether I would even call them still innovative financing because they are in the space already for some time. Health impact bonds, debt swaps for health, or blended finance. The first 2 maybe are less relevant for DFIs, but more on a government level, like to negotiate debt swap. Development bonds is a tool which has its justification because you can pre-finance certain interventions, and by this you much earlier can save lives. It's as simple as that. But at the end of the day, you still need someone who is paying for that bond. And third is the blended finance, where DFIs come into play, where you combine concession and public funding with private sector investments, and you can mobilize private funding to invest in health infrastructure. And what we also do more and more is also development of new products and technologies for in-country use, and we also discuss that later. And last, I would say, private sector engagement. We have John here as a representative, and they do that. If you look at how that works with tiered pricing, when I take a treatment, let's say in Germany or in the US, we know that there are the highest prices for treatments. Or for the products themselves, medical products. We know that huge pharmaceutical companies do offer that to a much lower price for instance, in low and middle income countries. So that is already a contribution. You still earn money, which is okay. You don't want to make losses. And the Access to Medicine Foundation, I think, is doing a very good job in trying to collect those data and to see what the big pharmaceutical companies are also doing to contribute.
Great.
I would stop at this point.
Thank you. That was a fantastic overview of all the different kind of financing options that we have at our fingertips. I'm keen, perhaps in the second round, to come into the why are some of these not really being implemented on the ground? Because we know what works, but the actual reality of financing for NCDs remains such a challenge. Emanuela, let me bring you in here. I mean, we've heard from both of our 2 previous speakers bringing in their own lived experience of NCDs. And as a lived experience advocate, living with diabetes yourself, I'm keen to kind of hear what your reflections are on the political declaration that was agreed, and how the inclusion of civil society and people living with NCDs have been included, and how you plan to use the declaration in your own work in Ghana after.
Sorry. First of all, thank you for that question. The inclusion of civil societies in the political declaration, first of all, is a long-awaited model that has actually helped move civil societies from consultation to active engagement in it. So what this means is that there's going to be more equitable and sustainable and accountable healthcare systems. But even though the political declaration did not necessarily meet the expectations of civil societies and advocates, well, the recognition in of itself is a validation of the importance of the inclusion of civil societies within the entire healthcare system in of itself. What this means is that it actually has opened way for us to be actively involved in policy making and monitoring. I would give the example of the PEN Plus model that has seen pragmatic impact and has actually helped because of the fact that there was the integrated approach and the inclusion of civil societies within the model itself. The next thing is the fact that though, again, it's been diluted from the zero draft itself, the mentioning Ghana, Mozambique, and Liberia, naming the PEN Plus model, and then actually seeing the impact of it, especially in remote areas where the most vulnerable exist, means that the inclusion of civil societies and advocates means we are going to be co-creators of it, as well as we are going to help with the shaping of the entire system in of itself. What that would bring into the conversation of implementation and what that means. What this means is that we are moving drastically from just actual conversations and policies to pragmatic impact and works that is being done. So on the issue of accountability and monitoring, what this means is that you have civil societies who experience the realities, actually holding the system accountable to ensure that what we have said we will do is what is happening. The next is on inclusion and participation, where we now have proximity to policymakers. So what this means, again, is that we actively contribute and we are able to bring out the priorities that should be on ground. Because she realized initially there would be policies, but they do not touch on the most pressing issue or what should be prioritized. So we have a lot of wasted efforts going on. But because of the inclusion now, it means that all these setbacks are going to be limited, and it's something that should be prioritized. The next is on direct access to communication. It means we have access to the front table, and we are able to put in the input of lived experience within the policy making, the implementation model, and also the feedback that we'd get from it, and how we'd move on from there. Thank you.
Fantastic, thank you. And I do think, I mean, having worked in the NCD space for quite a while now, I mean, I do think that the focus on lived experience and meaningful involvement of people living with NCDs is an area that we have seen significant progress over the last 7 to 10 years. I remember back in the first high-level meeting in 2011, the notion of having a patient advocate, a lived experience person on the panel involved in policy making, as you were saying, helping shape and develop services and health systems, it was just not part of the NCD conversation at that time. So I think it's fantastic that we have seen progress. And as you say, the declaration offers that kind of entry point. And in a way, the high-level meeting has strengthened civil society through the process itself. So thank you for sharing those examples. And also, just for the audience, in case you're not familiar with the PEN Plus, as you were saying, it's come up a couple of times. PEN for NCDs is the package of essential interventions for the primary healthcare setting. And in the Africa region, it's an extended set of interventions beyond the big 4, big 5 diseases to issues like type 1 diabetes, sickle cell disease, childhood cancer, etc. John, let me bring you in here. I mean, we've heard from many speakers kind of the importance of having primary healthcare as the kind of backbone of the NCD response. And the declaration, you know, this time round had a very strong focus on primary healthcare and integrated services, as well as specific targets around access to essential medicines and financial risk protection. Interested to hear kind of your perspectives on the declaration as a whole, but particularly what kind of concrete steps, policies and partnerships can be taken forward to really ensure that those targets are met in the next 5 to 10 years.
Okay, thanks, Katie, and thank you all for being here this morning. Katie, you and I sat last year getting ready for the declaration and talking about what that would mean. And I think it's hopefully a turning point for all of us that this will move into real action, because I think that's key. And Dr. Yanabe, I'll probably quote some of your points because I didn't write quick enough everything you said, but there's some really meaningful things in there. I think it's really great to hear that we're looking at community healthcare workers and healthcare workers in rural areas as a real resource that hasn't perhaps had the investment and the support in the past to deliver real healthcare level, particularly around NCDs. And I think empowering community healthcare workers, making sure they have proper training around NCDs, allowing them to be the real intervention for screening, which obviously starts with prevention. But building the capabilities at this level has a huge positive impact on delivery of healthcare. If we can screen and prevent, and then we can manage at a local level chronic diseases, this will make a huge difference to the overall healthcare system. And it's something over the last 3 years, as a global health unit since we started, we have now over 100 projects that we're in, many of them at rural healthcare level, that are making a difference. And you can screen a lot of people, and you can train a lot of healthcare professionals, so this is really important. One of the things that I think we shouldn't shy away from, as well as the use of digital technologies. Many people these days have some kind of communication tool, and we have to find ways to adapt that we can gather data, we can help people monitor their NCDs, and we can actually look at the difference we're making by our interventions. Because this is crucial as well in managing someone's chronic disease as they move forward. And I think it's something that we sometimes forget, particularly on the African continent, for example, that we can use these technologies, particularly investing from a private sector and a partnership point of view. I want to mention the partnership piece here, and I know we have some people here from Tanzania this morning. One of the big successes, if you want to make something happen at community level, is a partnership piece. You have to have a government involved. You have to have NGOs who can deliver on the ground and can be accountable on the ground. You have to have sustainable financing to make sure that once you set up the processes and the training and the capabilities, that will continue long term. So the partnership model is absolutely crucial, and agreeing a roadmap of how you're going to do that. I think from a regulatory and, for example, the World Health Essential Medicines list, I think one of the things that we find is that regulatory processes are very slow in countries, but also the rollout of guidelines. So when you train capabilities at a local level, people have to understand the international guidelines of how to use them. And I think we all as a partnership can play a bigger part in guidelines for NCDs and rolling those out for a better level of care. One of the big issues we find as an industry, never mind as just Sanofi, but also impacts people at a local level, is procurement and supply of medicines. Gerald, you mentioned pricing. Sometimes it doesn't matter what price we make things available at, and we try from our global health unit to make medicines available at a non-for-profit basis. If the infrastructure and the ability to get the medicines to a remote area is not there, then we're losing, because we've trained people to manage diseases and then the intervention doesn't get there. It's amazing you can get an ice cream or a tin of Coke to the middle of nowhere, but you can't get a box of medicines. So I think that's an area where we need to strengthen. We need to look at that supply chain, how it is built, and how we improve that. And again, that's through partnerships. On the pricing side of things, I think it's important that we look at how we make the supply chain as efficient as possible. We don't need so many middle steps in the middle, which only adds cost. And one of the areas we want to look at is that when we do our procurement processes, they're done incredibly efficiently, and that we get a better deal for patients at the end. My final comment is, and it's a comment that you made, Dr. Yanabe, where else can you invest $1 and get $7 return? So I think this healthcare investment is something that is a responsibility for everybody. And I love the idea that we should be talking more to finance ministers when we talk to health ministers, because that financing piece needs to be in sync with everything else that's going on from a strategy perspective.
Fantastic. So seeing NCDs as an investment rather than a cost, absolutely. And the best buys and the every dollar spent gets $7 back is a perfect example of that. We're going to do a second round, and then we're going to come for Q&A. So please do start thinking about kind of questions for panelists that you might have. And this round, we're really going to be focusing on what comes next after the high-level meeting and really digging into some of the solutions, what's working, picking up on the previous comments from speakers. And Dr. Janabi, let me come back to you. I mean, you were sharing some in your keynote about some of the success stories that you've seen in your region from an NCD perspective, whether it's around integrated primary healthcare systems, including from your country, Tanzania is a perfect example, as well as health taxes. But curious to kind of hear some more of those success stories that you're hoping to scale in the next 5 to 10 years, as well as how can WHO help governments make NCDs a priority in national plans and budgets, not just next year, but continuously and sustainably.
Yeah, thank you, Katie. At WHO, Afro, our vision, SDG 3.4, is to reduce premature death by 2030, at least for 1/3. And this really relies on 3 main pillars. One is integrating NCDs, as I said earlier, to the primary health care, where it's a backbone. This is where we are discussing about community health workers, and you said for me to cite examples. Before I started this job here, I was a senior advisor to President Samia Suluhu. In Tanzania was a target to reach 130,000 community health workers. And by the time I left in July, we were around 60,000 there. Because this is where, as I said, whether it's community, whether it's NCDs or outbreaks start in the communities and end up in the community. The second thing is sustainable financing and investment in cost-effective interventions. And this is where really we wish to talk with the Northern Globe. When we talk of innovative financing, you know how much our continent is spending on financing, furnishing our debts. So this is where it comes, can we do a debt swap for health? Instead of paying back the Northern Globe, can we use these debts to build primary health care centers for this innovative financing, branded debts, and involving the private sector, the civil societies, which have just been spoken, because we can't escape the private sector. They are the people with innovations and everything. So, and not, this is my personal, it's not WHO standing. CSRs, social responsibilities, are not sustainable. Yeah, they can't last for long. So the government have to understand about domestic financing. The other pillar is country-led, data-driven, because without our own data, and you're talking of Seychelles, I have 200,000 population, and you go to Nigeria, it's 225 million. So really it has to be a local priorities, and this is what we do, WHO, at all 3 level pillars. The country priorities, we try to tie them with the regional priority and then global WHO. So we are supporting countries in the frameworks, as I said, of PEN Plus strategy. We try to decentralize care of severe NCDs to a referral level facilities, to the model which really showing results. The countries I mentioned, Malawi, Rwanda, we are seeing it. And last but not least, the issue of health insurance for universal health coverage, it's very, very crucial. And for the private sectors, if you are here, I mean, the world has changed. The health has changed. The notion, for example, someone with cancer should not be insured. Actually, that's a very old thinking. If you insure, these people are living longer with the technology now. So it's a very cost-effective. So when we say to change, we really have to change on our mindset. That's the most important thing. The world has moved, and this is where we really think with technology. Yesterday, I had a ring which can tell you your sleeping pattern, can tell you if you have a sleep apnea, can tell you your blood sugar. And let me just finish. How many of you in the audience here, you know your numbers? Do you know your blood pressure? Do you know your blood sugar? What is your waistline? You're smiling, huh? Okay. Very good. For the gentlemen, just for a tip, anything above 40, your waistline is one of the signs of insulin resistance. For the ladies, my apology. Anything more than 35? So let me stop there.
Note to all of us.
Notable.
Gerald, in your first intervention, you were kind of laying out the different kind of financing mechanisms or tools that are available. I'd love to hear from you in terms of some of those kind of concrete examples and case studies where you're seeing progress made in financing NCDs or health system strengthening.
Okay, and I think that's a very good takeover from you with that ring that measures and controls. I try to give two examples of what Germany does through us, KfW, in addressing NCD innovations and interventions. For more than a decade, we invest in classic investment funds. Commercial investment funds, but we refer to them, and they refer to those to that themselves as impact investment funds in global health, because they have a focus that whatever they are investing into, our money, needs to be of immediate use and use in LMICs. So we are limited partners alongside with pharmaceutical companies, with philanthropies, and with other partners like IFC or BII. And we invest money in those funds very often on a concessional term. So the funds are structured. So you can invest in a low-risk tranche or in a high-risk tranche. And we take taxpayers' money to invest in the high-risk tranche to attract and enable private capital that maybe has never invested in something close to an LMIC impact. And then the fund manager takes the money and looks in what kind of promising young companies and startups that develop new products, new technologies that are of use in our partner countries, and give them the money, sit on the board, steer them and support them so that they can develop those new products and technologies. At the end, you still need someone who buys it and procures it. So it's important to see whether there are, in a given economy, there's a health insurance that would cover it, private or public, or you have a government intervention, a vertical that would pay for it, or structures like global multilateral schemes that would support that. To give you one example of that, we work with the Women's and Children's Health Tech Fund. That is a fund that is managed by a company, Cross Border Impact Ventures in Canada. They focus exclusively on women's and children's health and on late-stage technologies that they can invest into to roll out in low and middle-income countries. But not only there, they should make the money also in high-income countries. So we call that a dual market approach. So earn your money where you can earn the money, but you get only our funds and our investment only if you at the same time look of how you can roll those products or technologies. There's often also logistics solutions out in our partner countries. And we have one product here, just as an example. It's called CardioTech from a company, CardioScience, and that is a low-cost wearable device using artificial intelligence to non-invasively monitor heart failure, which is especially useful in LMICs, where those advanced diagnostics are scarce and the way to hospital too long, or to a health center, expensive and burdensome. Yeah, and this is an intervention which helps and even enables community health workers with some training in low resource and in remote settings to detect and manage heart failures, including postpartum cases, and connects patients to remote specialists via telemedicine. So the whole idea, and I see this wherever I go now to international medicine fairs and health fairs, and those young companies, they don't even know that all what they are developing is mostly or more relevant in LMIC than maybe in high-income countries, because it's low cost, easy to use, point of care, technologies and products that we are daring looking for to provide and implement or to introduce together with partner countries for the local population.
Great, thanks. And Emanuela, could you provide a little bit from your perspective and your work in Ghana, what barriers do young people kind of face in terms of access to care, as well as we look forward after the high-level meeting in terms of implementing the declaration, what does kind of meaningful youth engagement really look like and mean to you?
First of all, with my experience in Ghana, I would talk about 3 barriers that are prominent within the NCD space that should be addressed. And it has to do with the inequities that exist within the country. Because we usually talk about the inequities between wealthy countries and the LMICs, but you don't talk about those that are existent within the country, largely based, again, on your geographical location. I live in the capital, and I have more access than someone living in the northern parts of the country. So one of the problems that we have is on limited education and awareness. So it's not that awareness and education is non-existent. It is, but it is concentrated in certain parts of the country as opposed to other parts. So I'm going to use the example of diabetes because I live with diabetes, and you'd realize that I do have access and knowledge about diabetes management and have good control over my blood sugar levels. You'd go to the northern parts, and the lowest HbA1c you'd read is a 14, which is extremely high, and you realize the patients and the healthcare professionals there do not have adequate education on the management practices in of themselves. So it's recycling the problem without necessarily targeting those that are mostly needed. The second is on financial constraint. Again, with remote areas, as Dr. Janabi said, when we talk about remote, we mean like extremely remote, right? So you realize even with the issue of transport, to get to the nearest healthcare facility is a huge challenge because it takes hours, it takes days to reach the nearest healthcare facility. Personally, I live in the capital again, and the nearest healthcare facility is like 5 minutes away from me. So it's easier for me as opposed to someone living in a remote care center. And the third is on transition care. The issue we have with transition care is that it is where most patients are lost, where the issue of non-compliance and high mortality is recorded, because we do not have a transition care model to move patients from the pediatric level to the adult care system. So what this means, we need a streamlined and a consistent transition care model to be able to ensure that we are aligning the patients with the healthcare professionals that would be seeing them in the adult healthcare system, as opposed to leaving them to be and they getting lost within the healthcare system. That is why I think that solutions that so far I can talk about is that with the national health, the the national health insurance within the country has included diabetes medications like the soluble and then the orals on the insurance fund, but then also the inclusion of sickle cell medications as well. So that is like a step in the right direction and something we can work on. And the partnership, again, with the public-private partnerships, where they have partnered with Zipline to have medications through the drone system access rural areas. But that is still not enough because it is not meeting the target that is needed. In the implementation, we need three things. That is action, the actors, and consistency. So with the action is breaking the silos into the integrated system. We have way too many fragmented models within the country. We need to have an integrated system where there is a streamlined effort from one point of care to the other. So from the primary healthcare level to the tertiary to the tertiary level of care, where there's a streamlined process and referral processes, that makes it easier for care. The next is on actors. Currently, in the dispensation we are in, we have the most justice-driven level of individuals, that is like advocates and the youth, but they are also the most disillusioned because the system does not have any care model to give an incentive that they do care and they do think or believe that youth involvement and youth engagement is key and crucial. We do not have that, so we need to have an incentive to ensure that individuals who are passionate about justice and health equality and equity are actively included and at the forefront of policy making. And on the issue of sustainability and continuity, we've realized that we usually start things like pilot phases, but we don't have models of sustainability. And this is where the WHO Afro comes in with the PEN Plus model again, where there has been active engagement with the healthcare system. So it means that regardless of the political divide or regardless of the vulnerabilities that would occur, these healthcare systems or these models would be able to continue because there has been an active investment within the healthcare system, and they would ensure that continuity is something that is prioritized. So we don't have pilot models working, but then stopping because maybe one political party does not agree with what the previous government was doing. So this is something that should be prioritized on sustainability and continuity. Thank you.
Fantastic, thank you. And I think round of applause. Those three barriers that you outlined so clearly, including education, cost, and the transition care is a really important one that I don't think we really talk about in NCDs enough. And then the other aspect you bring in there, which has come out through other panelists as well, is just the sheer reality and challenge of fragmented health systems. It reminds me of when I used to work at the International Diabetes Federation, story of a man that lived in Cambodia who essentially said, I wish I had HIV and not diabetes. Yep. Because he knew down the road there was a fantastic HIV clinic and ARTs would be free. And unfortunately for him with diabetes, he has to travel across the other side of the country. Insulin was very costly at the time, et cetera, et cetera. It just shows the kind of inequities across global health and the challenge of the way that health systems are really designed today. So thank you for bringing out those really important points. John, let me come back to you. I mean, we've heard a couple of times this point about, you know, in Africa we're talking really rural, and we're talking kind of low-income countries. The real challenge of providing access in those communities and those settings. What role do you see the private sector playing in terms of driving innovation in access, particularly to those most underserved communities and regions?
So I think it's an interesting point on CSR can't last forever and do everything. I agree. And one of the mantras that we've put in place is that everything we want to work on has to have sustainability built into the project. So the project will have a beginning, middle and end. And then afterwards we always, before we've even started, look at how the work that's been done can be sustainable for the future, because this is crucial. It's almost unethical to start something and then not allow it to continue. But when we were building the global health business, we wanted to look at the whole holistic system and how it works. And one of the things that we realized as part of the conduit to make things happen was the incredible amount of entrepreneurs, particularly on the African continent, that have startup organizations or scale-up organizations that are part of the healthcare ecosystem for delivery. And when you do your clinics in the remote areas, or you do your training, or you do your delivery of products, etc., to medicines, etc., or screening products, we looked at setting up an impact investment fund of 25 million euros. And this is an in-house fund that allows us to invest in the entrepreneurs who are part of that ecosystem to help the delivery of healthcare. And this can be from delivery of clinics. We've done an awful lot around the logistics piece, around sustainable supply and continuum of quality of supply. But this fund now has invested in eight startup organizations. The interesting thing that the private sector can help with here, more than just the financial investment, is what we call sweat equity, which is where we use our internal resources. They can be supply chain management, they can be business planning, they can be legal, they can be regulatory, they can be all sorts of things. But we allow people within our organization to go and work very closely on a mentorship program with these startup organizations to help them accelerate what they're doing. And this has been seen actually by many of the startups as more valuable than actually the financial investment we've put into place. So this is one part of the model that is allowing us from the execution perspective to make it. So I can quote companies like Kasha that we've invested in Rwanda, M-Pharma, which is based in Ghana mainly, but all these organizations and the entrepreneurs have ambition to spread the word and to go in multi-countries. And interestingly, these entrepreneurs, I would say 90% of the time, have had a personal family health tragedy. And it's driven them to do something that's purpose-driven. And where we can help is from a financial perspective, from an expertise perspective, to help them deliver what is needed. And I urge anyone in this room who knows entrepreneurs, get them to shout at companies like us about funding and supporting them, because we have trouble finding enough people to support at times. You know, it's incredible. There's a gap there that we can help, and I think this is one of the most rewarding things we've done when we see these 8 organizations who struggle with business planning, they struggle with financing, but we can help them on that journey, and their impact into particularly the remote communities, into the society around the delivery of the overall healthcare model, particularly around NCDs, is huge. One other final thing that we've done is we created our own, what we call an impact brand. So it's basically Sanofi products in impact branded boxes with a generic name. We've put a QR code on these boxes so that you can actually scan the QR code and get the 42 different languages you need in terms of dosage and usage of the products. The other thing we've done this for is to try and support anti-counterfeiting and make sure that we continue through those sort of things. So in terms of implementing, we try to use a bit of technology, we try to use some funding. We also are using the support of our medical teams at rural level to help train community healthcare workers. You talk about the huge target you've had in Tanzania to reach. These ambitions are crucial, and I think that the planning, the measuring, the monitoring, the KPIs of this and helping people to manage on that side of things is crucially important. So it's a whole mix of things, but the partnership, the drive to make it happen, the measurement afterwards, and I think the sustainable financing is a crucial part of what will make this successful in the future.
Great. Thank you. Dr. Janabi, I'm just going to ask you one more question before we come to the audience, because it's obviously a big theme of this World Health Summit, which is obviously the kind of reimagining of the global health architecture at this kind of critical kind of juncture for health. Curious to hear from your perspective, from a WHO Afro perspective, how you see that that process going and what the implications are for NCDs. And as I say, after Dr. Janabi, we're going to open it up to Q&A from the audience.
Well, it's a broad question, and let me break it into pieces. I think whether it's a declaration, implementation, there are three key things: accessibility, availability, and affordability. That one is a backbone. Two, as Afro, and we've been talking with ministers and government, it's what happened the beginning of this year when the ODAs went down by 70%, when our biggest donor stepped down. To us as Afro, is a great opportunity. I don't sit down and cry about it. We need to take the ownership of our health. We need the sovereignty, and you have seen on Accra Impact by President Mahama. She gave a very good example. I was there when it was launched, and the cross-information between African countries has to be high. You're talking of Ghana, 60% coverage on health insurance, Tanzania less than 10, so they need to go and learn from them. You're talking of Nigeria, maternal mortality rate over 800 per 100,000 live beds. You go to Lusaka, it's 85. So information between us is good. And I candidly talk with the ministers. A patient with hypertension or diabetes or mental health in Nairobi does not worry Berlin, does not worry London, does not worry New York. It's not Ebola. So we have to take that ownership of health. We have to invest on health, especially on sustainable financing, because this is our biggest issue. And at the WHO on the 14th of August, we did this global town hall meeting. So all our 6 regions, so I presented for Africa. And we had 3 columns. What are our priorities? What WHO will scale down a little bit, and what WHO cannot do anymore because of the financial gaps which we have. So our partners, Sanofi and others, to have a coherence, we really need to talk to each other to avoid fragmentation, to avoid duplication, because the reality is there. There is a financial uncertainties, there is a geopolitical tension. We didn't discuss about climate change. How can we build more resilient healthcare systems? And a question of involving the private sector, philanthropists, civil society, faith-based cannot be avoided in our era. And let me finish you. I have small islands there. We call them seeds, Seychelles, Mauritius. Literally, they're importing everything, and this is processed food. So NCDs, to us, it's really a huge priority now, and we are running up and down to see how we can talk about it. But all in all, prevention is the best way to approach it. You need to exercise 10,000 steps a day. You need to eat healthy, sleep, which is debatable, have enough water, but it's cheaper to invest on that. This is what I can say. And this is not only for the continent, the audience sitting here. You have to exercise.
Thank you. But I think I completely agree. But also, I guess the beauty of the best buys that we have on prevention are all about changing the environments that people live in, so that those healthy options are essentially the default option for people, which it's so difficult in so many low middle-income countries and high-income countries as well.
Yeah, this is where WHO, we talk about One Health approach, because it's 75% of our outbreaks, they are zoonotic. They come from animals. That's why now, even in DRC, we are going to start to look on our surveillance, not only on humans, which we are following over 1,000 contacts now of Ebola, but we want to look on the reservoirs, and we want to incorporate the culture and everything. So it's really urbanization, our planning, WASH approach with hand wash. So it's really not about Ministry of Health per se. It's a multi-secretarial approach will make this world more safer.
Great, thank you. So we're going to come to the audience now, and I'm hoping we've got some minutes left, so we'll try and come to as many of you as we can, and then we'll come back to the panel. I'd like to start, though, with by bringing in Anne Burr from IFRC, Special Advisor to the IFRC Secretary General here in the front row, to bring her in to kind of ask a specific question to IFRC, really. In the current era of polycrisis that we're all living in, escalating humanitarian crises around the world, how well do you think kind of integrated care models, it's been a big topic of today, are being implemented as part of the humanitarian response, and how much are NCDs being included in that response?
Okay, yeah. Thank you very much. And thank you also to the panel and to Dr. Janabe for some sound medical advice. And it's been very interesting to listening to the panel. And to your question, integrated care models are advancing, but still unevenly across the humanitarian context. So many response systems are designed for acute crisis, for epidemics, for trauma, for displacement. And I believe, and I think we have to admit that, it's still chronic conditions and mental health are treated as secondary. At the IFRC, we are working to change this through a clear operational shift. The goal is simple, to make continuity of care for mental and physical chronic diseases part of what defines a life-saving response. And I think that is one of the key things, that it actually comes under the life-saving response. We already see this shift in practice. For instance, I would like to mention in Syria, the Syrian Arab Red Crescent Society developed a multi-hazard emergency plan that included NCDs as a core element. And during the 2023 earthquake, their mobile health teams continued providing treatment for diabetes and hypertension. This example simply shows that when preparedness anticipates chronic care, continuity is possible even in the midst of crisis. Still, NCDs remain, as has been talked about, underfinanced, underrepresented, also in humanitarian planning. And at the IFRC's role is to shift that narrative. We will use our auxiliary position with governments and advocate that NCDs and mental health must be treated as essential public health priorities, not optional add-ons. Earlier this year, the IFRC Global NCD Advocacy Bootcamp brought over 60 participants to define collective policy asks for the 2025 UN high-level meeting. And the message was very clear. Goodwill is not a strategy. We need preparedness, financing, and accountability to go hand in hand. So while NCDs are still too often sidelined, we must build on the positive signs that we are moving from ad hoc responses to structured integration, anchored in preparedness, delivered through communities, and sustained by partnerships, as also have been mentioned here very clearly. I think it is possible, and I think it is also much overdue, the time-wise. Thank you.
Thanks very much. And I think the other aspect of the humanitarian NCD policy response was that in the lead up to this high-level meeting, there was also that fantastic NCDs in humanitarian settings meeting that happened in Denmark, really putting a spotlight on the issue, on the need to be kind of really integrating NCDs into the humanitarian response. So thank you for that. We're going to come to a couple of questions. I see this gentleman near the front, and I'll come over here for the second question. If you could say your name and be as kind of concise as you can with your questions.
Hello all, good morning. My name is Rajiv. I am from India. I have just two specific questions. First one to Emanuela. Thank you for this wonderful talk. You spoke so much about the civil society representation and having a place at the table. But I also feel there is increasing curbing of the voice of civil society, and given the current geopolitics, what are your thoughts for those in this current scenario of how increasing spaces are curbed? And second, for the general panel and others, When we talk about NCDs, we still talk about the big fours: cardiovascular diseases, cancers, lung diseases, or mental health. The big things feature. But there are so many other diseases like oral health are also being neglected. So it doesn't get really featured. I just want to hear your thoughts on, is it really required to make it more specific, or how do we prioritize many other neglected issues within NCDs also? Thank you so much.
Two great questions. Thank you. Let's come over to this gentleman here, and I'll try and take one more. If I saw a woman over here. Yep, on the right. Okay, quick fire.
Thanks very much. Keith Martin, Executive Director of the Consortium of Universities for Global Health. Dr. Janabi, I think you hit the nail on the head in how we move from declaration to development. And we know that the power at the cabinet table is not the Minister of Health, it's the Minister of Finance. So let me ask you, do you know of any countries that are actually bringing together the ministries that are actually vital to addressing NCDs? Ministers of Finance, Ministers of Health, Ministers of Trade, Ministers of Agriculture. Because that tiger team of senior public servants, I think, is the mechanism to be able to scale up and secure the political commitment and implement the political commitment with the long-term domestic financing to implement the low-hanging fruit. That's the cost-effective way to address these challenges. So can you share with us maybe how that can be done, or if that's being done? Thank you.
Great question. And one more over here.
Thank you. I'm representing AT-Scale. It's the Global Partnership for Assistive Technology. My question echoes a little bit the gentleman there. We've heard quite a lot the issue of the importance of having ministers of finance at the table and influencing ministers of finance. And Dr. Janabi, I wanted to know, do you have any good examples of where the advocacy towards ministers of finance in low-income countries has been successful? And to Katie, I wondered whether the NCD community have considered taking the high-level meeting from the UN in New York to the World Bank in Washington and convening a meeting of ministers of finance and other stakeholders akin to what the Sanitation and Water for All Partnership, for example, have done in WASH.
Fantastic question. Thank you. So we'll come back to the panel. Emanuela, if I could come to you first. There was a question there about kind of shrinking civil society space, and how are you seeing that, and how can we try and avoid and mitigate against that, essentially?
So with the problem of curbing the voices of civil societies, it has been one problem I have had with the inclusion in of itself, because it feels performative and tokenistic at best in most instances. And the issue is you'd speak and they'd not listen here, but then they'd go back and do what they've already planned to do. And you only realize it when the policy comes out. But I think where civil society still plays a role in the inclusion, I'm going to give the example of the UN General, their political declaration. As I said initially, it was a bit disappointing that we were not really spoken about, or we were not given that much time within the whole political declaration in of itself. And that brought about weak accountability mechanisms where there is no clear mechanisms in which we could hold them accountable for the declarations. But I think that should be the point at which we capitalize this very weakness and use it as a strength. When I say this, what I mean is the fact that we have been recognized means that we do have the legitimacy to speak out. So it means that this is the first step we can take to ensuring that we can push back against just being tokens for the whole political talk and actual work being done. What this means, again, is that we can go and hold our systems accountable, and that is where the problem comes in, where the whole skepticism is an issue, because you realize that the system in of itself has failed us. So being able to hold a system accountable means that we are able to push back on policies that do not prioritize what needs to be prioritized. And this means tying it into the incentives of the political space in of itself. When I say tying it to the incentive, I mean things like political will and financing. So the only reason why your political leaders would want to actively invest in NCDs is because when the community speaks out and prefers that to be what the government should do, it means that for them to want to be in power for the next time, they are more likely to put in steps to ensure that the community gets what they want. So this starts with us actively doing the work on the ground and letting the community push back. So not just civil societies, but then every individual within the country should be part. And the only way that can happen is if we form relationships within the community for them to want to listen to us and hold the government accountable through the systematic processes that have been made available to us. Thank you.
Thanks, Emanuela. And I think actually a good kind of example of that in a way is, today we've actually got 75 national and regional NCD alliances around the world. And those are kind of platforms, as you're saying, that are actually kind of positioning themselves, obviously, as kind of bringing the whole civil society community together to be emphasising the importance of NCDs and working with governments to support implementation. So I think that kind of coalition approach in NCDs is so critical. Dr. Janabi, there was a few questions there for you in terms of the, how do we, are there good practice examples of when whole of government is coming together around NCDs beyond Ministry of Health, Ministry of Trade, Ministry of Finance? Where are you seeing that happening?
Thank you. Let me just collectively, but I think there were two questions which were overlapping each other. And one, there was from a gentleman there. I'm really not a very strong believer of low-hanging fruits. I'm a believer of planting trees. Fruits are seasonal, and they keep coming on. So I always encourage ministers to plant trees. Just coming from two big meetings, one in Lusaka, the Regional Committee 75, but I was in Brazzaville just last week. Meeting all our WHO representatives from the 47 member states. And we discussed a lot about the domestic financing. And let me cite you, wanted a concrete examples. Last month I was in Abuja, and there was a health sovereignty meeting, who was in the hall? Apart from we, WHO as representative, we had Minister of Finance, we had Minister of Planning, we had Minister of Health, we had parliamentarians, we had the speaker. So the approach really, I think, is all about awareness, knowing that now you cannot work in silos, but you have to work as a team. And I think the continent is trying to look on things on a different way. That when you have a healthy population, it means they're not going to miss, they're going to be more productive, and the economy of scale will definitely turn around. I was in Ghana in the month of, I think, beginning of August, and Emanuela can attest to that. The Accra Accord is about financing, and all the ministers which I have just mentioned. So the continent is changing. The GPS, I think, is really turning on the right direction. End of the day, we have to have that domestic financing. We have to have that sustainability plan. So there are many such an example. And we as a WHO, being a normative organization, for Ghana, we promised to send experts there on financing and to see how the domestic financing means. Likewise, in Nigeria, we are going to send expertise on the cost of the WHO, because our biggest strength is on expertise, not money. So that approach, I think, it can benefit our continent. And just to finish, just to remind everyone, every year 1 billion people in our developing countries are turning into poverty because of out-of-pocket. On average, in African countries, more than 60% of the health bills is out-of-pocket. It's something which we really need to put it into a stop. Those countries which I've mentioned, Nigeria, for example, 70% is out-of-pocket. Now with NCDs, which are pretty expensive, someone has to do something, and not tomorrow, but yesterday.
Thank you. Well, I thought we were doing really well for time, and suddenly we're at 90 minutes, so fire the moderator. But please join me in thanking our fantastic set of panelists today. And thank you to Sanofi for the partnership in bringing this session together. I think we've covered a huge array of different issues, from access to care, to prevention, to financing. But above all, I think we've heard the importance of rooting the NCD response in equity, the importance of action and accountability after this high-level meeting, and the importance of really rolling up our sleeves and increasing the number of partnerships that are out there on NCDs to make sure that we're reaching the most vulnerable populations. So thank you again for joining me, and thanks for joining the session to all of you.